Welcome to our broadcast. I'm your host, Sarah Vaezi. As a reminder, the information provided during this event is for information purposes only. If you have any questions around the COVID pandemic, please visit our website at providence.org or visit cdc.org for their official medical updates. This event does not create a doctor-patient relationship, and any questions or medical advice discussed is not considered guidance on what you should do. For any medical questions, please reach out to your primary care or healthcare professional. Now let's begin. Joining me during this live event is Dr. Ari Robachek, the Providence Chief Medical Analytics Officer. Welcome, Ari. Thank you for joining.
Happy to be here.
Well, let's start. Why don't you tell us a little bit about your role at Providence more generally?
Sure. What does the Chief Medical Analytics Officer do? So by background, I'm an infectious disease doctor and hospital epidemiologist, and I spent a bunch of years doing research, especially related to antibiotic-resistant bacteria, and eventually I found myself chasing data in large populations to help understand the movement of antibiotic-resistant bacteria through populations, and so I ended up getting involved in working with large clinical data sets that come out of electronic medical records. And one thing led to another. And over the course of a number of years, I found myself doing general data work using electronic medical record data. And so I was in Chicago for a bunch of years where I had the opportunity to develop a clinical analytics data shop. And I've been here at Providence for the last 4 years or so in this funny sounding role, Chief Medical Analytics Officer, which basically means that I have the amazing good fortune of leading a team of individuals who are extremely good at extracting, organizing, analyzing, and telling stories with data, where our purpose is we collect a ton of data in the context of caring for patients. And the question is, can we use this data to help improve patient care? And so the team does a lot of work in general related to finding ways to use data to optimize care. Some examples have to do with developing quality metrics to help us look at the quality of the care that we're providing. We do a lot of value-related work as well. And so we think of value simply described as quality over cost. And what we do is look at variation around our system to help identify the optimal way of caring for our patients, ones that methods of care that lead to great quality and at excellent cost. A lot of the work that my team focuses on has to do with patient-reported outcomes. Patient voice is something that traditionally has been fairly absent in what the sort of data that we collect in healthcare, but it's absolutely critical to help us know, are we doing a good job, and are our treatments actually helping patients? Some of what my team does is special projects. So we've built a tool for physicians called CAKE. It's clinician accessible knowledge engineering, and the idea there is that doctors can customize the electronic medical record to help optimize their practice. And so you won't be surprised that a lot of what my team has focused on over the last 6 months is COVID. I eat, sleep, and dream COVID.
Yes, and our system is so grateful that you are doing that. Given the context of bringing all these really complex data sources together and gleaning insights about patient care, can you connect that to what you're doing with MyCovidDiary and what the project is about? Just start with giving us a bit of an overview of what it is, what data you're going to be collecting.
Yeah, for sure. So I'm so excited that the organization was able to support this project in collaboration with Twistle, and I'll talk a little bit about that in a minute. But this is, I think, a really important project. So COVID came along, it's a brand new disease. There's not a lot that we knew about it. And one of the things we found very early on is this is not your usual virus. This is not your grandmother's usual viral infection, you might say, right? It's not the flu. It's not the common cold. we learned very early on that it manifests in strange ways. So for example, early on, the way we screened for COVID was looking for fever. Well, I can tell you that in recent months, among the patients who we've admitted who have confirmed COVID inside our healthcare system, 40% of them don't have fever, right? So things that we thought were consistently present are definitely not consistently present. And conversely, we've learned a lot about symptoms that are very bizarre and that we didn't expect that are features of COVID. For example, anosmia, the loss of smell, right? The initial patients who presented to their doctors with loss of smell, had that symptom kind of shrugged off. But we now know that it's one of the most important manifestations, one of the most specific characteristic manifestations of COVID. Quickly, we learned that there were other strange things that COVID was doing. There's this thing that some people refer to as COVID brain fog. There's COVID toe, where you get these kind of blue, painful toes, right? My sister, interestingly, in Canada, suffered from what I'm pretty sure was COVID, although she wasn't able to get tested in time to confirm that. But she ended up having respiratory manifestations like chest tightness that lasted for several months. And she had panic attacks, which is not something that she's had in the past, in association with this chest tightness. And subsequently, I've read a number of patient accounts that have specifically described chest tightness and panic attacks. And these are people with confirmed COVID. And so all of this got me, with my infectious disease background, thinking about just how little we know about this virus, both in the way it manifests in patients and how long these manifestations are expected to last. And so when a patient shows up at a doctor's office, it's very hard for a doctor to know whether the symptom that they're experiencing, is that likely COVID or not? And when the patient asks the question, how long is the symptom going to last? Doctors don't have a lot of information to draw on to answer that question. So typically what happens when a new disease arrives in the world is that over the course of years, textbook entry is compiled. And usually that textbook entry is developed by somebody who's viewed as an expert. So they're usually somebody in an academic institution who becomes a specialist in that very specific illness. And they see hundreds of patients over the course of many years with that illness. And based on that physician's experiences, they then write the textbook entry. Here's how this disease manifests. And there are a few problems with that. One is that it tends to be from the perspective of one or a small number of physicians rather than patients. Number two, it takes years to compile that information. And number three, as you and I have talked about before, there's this very interesting series of steps in between a patient experiencing something and it getting into a textbook, right? First, the patient experiences it. A few days later, they describe those experiences. But oftentimes, they don't describe it exactly the way they experienced it. One of the reasons is that you just forget stuff, right? Another is that you might be kind of self-editing to explain things in the way that you imagine that somebody wants to have that information formatted, right? Then the physician hears what the patient is saying, but often only pays attention to those clinical features that they're looking for. So if you say, I lost my sense of smell, but the physician isn't thinking about that as a manifestation of anything important, then they're not going to really hear that information. And then there's this bridge to be gapped from what the physician hears to what she actually writes down in the patient's chart, right? And so the question was, could we find a way to way more rapidly develop that textbook entry on what the manifestations of a new disease are, using new technologies that allow us to go directly to the patient and hear that patient's voice at the moment or close to the moment when they're actually experiencing these symptoms, so that we could much more rapidly compile data, we could get a much broader range of voices, and we can skip all the sort of series of steps at which information is lost. Can we go directly to the patient and hear patient voice? So fundamentally, MyCovidDiary is about using new technologies to reach out to patients who we know have COVID inside our healthcare system and give them an opportunity to journal over the course of a full year what they're experiencing.
And how are you delivering this journaling experience to them? What are some of these underlying new technologies that are powering this?
Yeah, it's pretty awesome. So our system's been using for a while a tool called Twistle. Twistle is a patient engagement company. They are very good at reaching out to patients via patients' mobile devices, and then having those patients follow a particular clinical pathway. So if you're a patient who's preparing for a particular surgery and 7 days before the surgery, you're supposed to do certain things or document certain experiences, you can do that on your mobile. You'll be reminded about it and do those things on your mobile phone. Let's say 1 day before surgery, you're supposed to fill out a form. You can do that on your mobile phone. 3 days post-op, you're supposed to do things. Again, you're reminded on your mobile device. And so it was really you and your team, Sarah, who said, hey, Twistle would be a great partner for this project. And they've really proven to be. So what we've worked with them to do is to design we call it a pathway, where once individuals are tested positive within our system, we reach out to them via their mobile devices and offer them the opportunity to participate in MyCovidDiary. And if they say yes, they want to participate, then over the course of the year, we send them periodic reminders where we actually give them a little form to fill out with a very short number of sort of structured questions about symptoms. And then we give them a place to just document what they're experiencing. And we do that, like I said, over the course of a year.
Wonderful. So you'll be gathering quite a bit of data through this year-long pathway for all the patients that are testing positive, that are signing up for it. What are you going to do with the data on the back end? And I know you'll be using natural language processing. So could you tell us a little bit more about natural language processing and what's going to be the role of it in this study?
Yeah, so that's where other cool technologies can be brought to bear. Our hope is that we'll have thousands, perhaps many thousands of patients who participate, and every patient is gonna bring their own voice to describing what they have. Ultimately, then imagine that we have journals from thousands of individuals, and what we want to do is take that data and turn it into the way I visualize this is a timeline that represents the natural history of COVID, where, here's how many patients at this point in the timeline experience this symptom. And here's how many patients at this point in the timeline are still experiencing that symptom. Same thing for a whole host of symptoms. And so in order to translate, to go from, we've got this pile of journals, a stack of, patient written journals, to a timeline that providers and patients can use to understand what to expect over time, we need some way of processing all that patient entered data. And we very intentionally set it up so that the patients could enter their data, because we didn't want to assume up front, we didn't want to put words into anybody's mouth, and we didn't want to assume up front that we knew what all the manifestations of COVID were going to be. So we make relatively small use of actual forms for people to fill out. And so we need a way then to process all that patient-generated self-described information. And so that's where natural language processing comes in. We've been, over the course of the pandemic, training tools specifically to identify the types of symptoms that we think that patients are going to experience. And we've actually done that by building a data science pipeline that presents to clinicians like me, I'm one of the annotators involved in this, actual text, where we then look at that text, identify clinical features, and then train the machine learning tool on how to interpret that clinical information. So is the person saying that they had it, or is the person saying that they didn't have it, or is the person saying that they're worried they're going to have it, or is the person saying that their sister had it, et cetera. And then these machine learning models can be used to look at new data sets or new text that it hasn't seen before, to translate that ultimately into these specific features. Were they present or were they absent? So that's how we're hoping to process all of that data using the technology that we've already developed. And specifically, we've developed it at this point on clinician written notes.
That's amazing. So you're going to be doing this. You'll be collecting data for about a year, but when will you be sharing preliminary findings? Will it be at the end of this year-long period, or will you be sharing findings along the way?
Yeah, so it depends on how many patients participate. My hope is that within the first, we just went live a couple, 3 weeks ago. My hope is that within the first 6 months, we'll enroll 1,000 patients at least, so that 6 months in, or maybe 8 or 9 months in, we'll have a really sort of substantial section of individuals whose voices we're able to compile. So my hope is that if we get robust enrollment within 6 to 8 months, we'll be able to start actually presenting the data to the public. And one thing that I'll say is that we have committed to presenting the data first to the patients who are participating.
That's great. So that's one really interesting benefit for the participants of the study. Are there other benefits that participants get through participating in MyCovidDiary?
So what I would say is that, we make it clear up front that we don't compensate anybody for their effort or their time. But we hope that some people are going to be excited about the idea of being citizen scientists and helping to combat the pandemic using these new technologies. And the way I frame it in my mind is this is an opportunity for individuals to take a bad personal situation and turn it into something that's beneficial for the world. And so my hope is that there's going to be a substantial section of the population of people suffering from COVID who find that motivation enough to participate.
That's amazing, and what an opportunity for folks to turn something terrible into something that hopefully helps our communities. How does this fit within the overall kind of scheme of data analytics as you've been using them within Providence? And in particular, since the COVID-19 pandemic started, you all have done such amazing work. Can you tell us a little bit more about the broader work, and then how does this fit within that?
Yeah, sure. My team's been very busy. I'm the person who gets to talk about the work, but in fact, I'm not the person who's doing most of the work. It's really just a fantastic group of individuals who I'm privileged to work with who are doing this. But I divide their work into three categories of things. One is awareness. So a lot of their work is around situational awareness. So how many patients with COVID do we have in our hospital right now on mechanical ventilators, and how many extra mechanical ventilators have we got, so that we can make decisions around, do we need to move ventilators from one place to another? So that's situational awareness type reporting. Another type of reporting and analytics is on learning. And so learning there is around things like how can we use our experience to help identify what the optimal way is to treat patients with COVID. So, for example, we've been involved in a number of comparative effectiveness studies looking at our data across our 50+ hospital system to help identify what are optimal therapeutics for patients. Another type of learning has to do with just observing what's been happening in the context of the pandemic. Like, one of the more extraordinary findings that I've been involved in analyzing has been the huge drop in volume of patients with acute illnesses in our emergency departments since the beginning of the pandemic. So, one of the things that we saw is that patients were coming to us less for acute myocardial infarction, so for heart attacks, for gastrointestinal bleeds, for severe asthma attacks. And the question is, like, how much of that is people really are experiencing these things less during a pandemic, and how much of that is people are not coming to us when they're sick? And my worry is that a fair bit of it is people not coming to us when they're sick, because we're seeing an overall higher mortality rate among people who have those severe illnesses in an absolute way. So, for example, when you take pneumonia, we're seeing fewer patients come to the hospital with pneumonia, but a higher absolute number of patients die of pneumonia. So one of the things that we learned from that is the critical importance of reaching out to our communities and talking about how important it is to come to the hospital if you actually do have an illness. Another analysis that my team has done looks at are our emergency departments actually safe, or are people picking up COVID in our EDs? And I'll just sort of cut to the chase on that large case control study, but the bottom line is that we're seeing no evidence that patients are picking up COVID in the ED when they come to the ED for a non-COVID reason and spend time in the ED with patients who do have COVID. So that's good news, and that's an example of important learning for us to disseminate. So category number 2 of analytics is learning in my mind. Actually, another thing that I'll point out in the learning category has been around disparities. So for me, one of the most shocking and upsetting things that's come out of our analytics has been the things that we've seen around disparities in the acquisition of COVID. So on the West Coast, we care for a large Hispanic population. And one of the things that we've seen is that the pandemic has changed from in its early days. The people who we admitted who were super sick with COVID were especially old white people. And that's changed in recent months. Now we admit a lot of individuals who are middle-aged and Hispanic, who have severe disease with COVID. And that population is represented in our hospitals with severe disease in a way that's much larger than their demographic representation in our population, suggesting that there are important risk factors in the Hispanic population for acquiring COVID and or becoming very sick with it. So anyway, that's the kind of work that we do on the learning side. And again, we can take that information to our, for example, to a branch of our organization that's specifically focused on creating support in our community in areas where it's most needed. And they can take that information and set up testing centers, for example, in areas that have predominant Hispanic populations. And then the other category of work that we've been involved in is prediction. So some of that is prediction at the level of helping a clinician make a decision, like I'm seeing a patient in the ED. Are they safe to send? I think they have COVID. Are they safe to send home? Or is this somebody who's likely to deteriorate? Do I need to admit them? And so we built predictive models to help with that. And some of it is prediction on the system level, like how busy is this ICU going to be 2 weeks from now? And so, one of the side benefits of the MyCovidDiary project actually is we can take some of the learnings from that project about how does COVID manifest and then use it for a separate project on syndromic surveillance. So the idea of syndromic surveillance is looking at what symptoms individuals who live in a community are experiencing. And what we found is that even with our relatively simple natural language processing to date, without the benefit of the MyCovidDiary data, when we look for just basic things like fever and cough and shortness of breath, what we find is that the amount of fever, cough, and shortness of breath in a community today predicts how many COVID patients our hospital is going to be caring for 10 days or 2 weeks from now. And so, a side benefit to our communities of the MyCovidDiary project will be improvement in our syndromic surveillance tools to help us operate better as a healthcare system.
That's incredible work. Are there any other sort of new programs that you can talk about, or how do you see these three sort of areas around situational awareness, learning, and prediction carrying forward beyond COVID potentially? Hopefully we come out of this thing in 18 months or less. But are there things that you see on the horizon, new projects or longevity associated with these three kinds of categories that you can you talk about
sure.
those?
I think we will have benefit as an organization in all of those areas. Situational awareness, to understand what was going on with COVID. We needed to develop tools to help us better understand what was going on in our hospitals in general. So we've developed a lot of analytics and reporting to help us understand capacity, for example, and sort of where patients are. And we're now leveraging that forward into more sophisticated projects around understanding and optimizing patient flow through our hospitals, which is, if you've ever been a patient in a hospital, you will know that flow can feel, frustrating and disorganized, and you feel like you don't really know that somebody's really communicating with you about when you're going to be able to go home. Well, that's very common in healthcare systems, and we feel like many of the tools that we've developed for COVID to help us develop that situational awareness will be helpful in this future work. On the learning side of things, so we've actually developed a lot of capacity inside our healthcare system, which is largely not academic, although we do have academic sections within the Providence healthcare, very prominent academic sections within the Providence healthcare system. But we've greatly expanded our academic ability and actually have already had sort of a number of publications, and we've been able to support a number of young investigators in their sort of growth in the context of COVID, but in a way that I suspect they're gonna leverage forward for other things after COVID. And then on the prediction side, one of the coolest projects from my perspective is something called Detection Map that we're working on right now, which will be a tool that's public facing that will allow any individual to see the prevalence of various types of conditions in their neighborhood based on syndromic information coming out of the electronic medical record system. So one of those is going to be COVID. Another one that we're building right now is influenza. And the hope is that we'll be able ultimately to layer many more conditions on top of that.
That's incredible. With our last minute here, any final things that we didn't touch upon that you'd like to share with folks, whether it's about MyCovidDiary or more generally the clinical analytics work that your team is leading across the system?
Boy, well, I think more than anything, I want to express gratitude for the opportunity that your team has provided in connecting us with folks who are really able to make MyCovidDiary happen, and appreciation for the super talented analytics people who are actually doing the work that I've been talking about.
Yes, we are. We're all very grateful to them and the contributions that they've made. So thank you so much, Ari. This was fantastic, as is all of our conversations. So thank you for your time, and thank you to all of you for joining today and for listening and joining the conversation. To learn more about our initiatives, programs, services, and ways to give, or if you are looking for medical care, again, please visit providence.org. And make sure to follow us on social media. We'll be continuing to do events like this. You can find us at Providence Health System for LinkedIn, Facebook, and Instagram, and under Providence on Twitter. So thank you again for joining, and hope everyone stays safe and well.